So my talk for the day is clinical examination of the shoulder. If you consider shoulder joint, it is one of the most complex joints as far as clinical examination is concerned. More often than not, the diagnosis is clinched by getting a specialized investigation like MRI done. Although a structured clinical examination will clinch at least the broad category of the disease suffering from, but the key word is structured clinical examination. Not to overemphasize, but in any clinical examination, the most important part is history taking. And few points from the history would probably lead you to a better diagnostic or a better diagnosis. First and foremost is the age of the patient. It is a very important parameter as it probably tells you regarding the pathology the patient is suffering from. We can grossly divide the patients into two groups. One, below the age of 40 years, and second, above the age of 40 years. If you consider patients above the age of 40 years, the pathologies which come to your mind are probably rotator cuff disease or a cuff tear, subacromial impingement, acromioclavicular joint arthritis, subcoracoid impingement, bicipital tendinitis, and adhesive capsulitis. At the same time, if the patient who is presenting to you is less than 40 years of age, what comes to our mind is probably instability, which could be antero-inferior glenohumeral instability, glenoidal labral tears, which could be anterior or posterior labral tears. It could be a flap lesion, the lesions of the long hair of biceps, supraspinatus tendinosis, and acute calcific tendinitis. So just by dividing patients into two groups, you have probably thought of one of the pathologies which probably the patient is suffering from. The second important point in the history is pain. We have to understand and know what is the grade of pain on a VAS scale. Plus, sometimes you have to ask leading questions as to whether the pain worsens at night, whether it radiates from the neck, and what are probable difficulties in doing activities of daily living. For example, if the patient's pain worsens at night, then a probable condition the patient is suffering from could be a cuff disease or adhesive capsulitis. If the patient has got radiation, it could be due to a cervical disc disease. Loss of abduction will suggest a cuff tear, and a global painful movement would suggest adhesive capsulitis, which could be either due to a diabetes or could be a secondary adhesive capsulitis due to rotator cuff disease. The third point in the history is to ask about limitation of range of motion. Pattern of movement restriction will probably guide us or guide the clinician to a diagnosis. When it comes to basic assessment of the shoulder, as we all know, the shoulder is assessed, or any joint is assessed as to see, to feel, and to move, and then do some specialized tests. So when it comes to basic assessment, the first point is inspection, that is to see. One must clear the cervical spine before touching the shoulder. The basics of assessment are: uncover the patient. The patient's back and the shoulder should be free from clothes. Examine for any wasting, scars, sinuses, or prominences around the shoulder. See for active range of motion. See for passive range of motion. Then do a resisted isometric testing of the individual muscle groups, and also look for proprioception. In inspection, as we said, we have to see for the shoulder contours, whether both the shoulders are level or not. There is a marked internal rotation of the shoulders, which one can see in professional swimmers. Whether there is any prominence of SC or AC joints, wasting of the supraspinatus or infraspinatus, old surgical scars and sinuses, and more importantly, the scapulothoracic rhythm. So in active ROM, one needs to assess following movements, which are elevation through abduction, which is about 170 to 180 degrees in normal patients, elevation through forward flexion, which is again 160 to 180 degrees, extension, which is 50 to 60 degrees, external rotation, which is 80 to 90 degrees, and internal rotation, which is done by a thumb hitch method. One should be able to reach about dorsal 5th to 10th vertebra to say that it's a normal. Adduction is around 50 to 75 degrees. Along with this, horizontal adduction, protraction and retraction, along with elevation and depression of the shoulder should also be assessed for. Active ROM is always done in standing position. To give you an example, this is active ROM, which is the first video which you see is forward elevation flexion, which is 160 to 180 degrees. Whereas if you see extension, it is about 60 degrees. One needs to understand that this situation, one should see that the torso remains erect. A forward elevation can be compensated by excessive lordosis at the lumbar spine. At the same time, the extension can be compensated forward flexion. So one has to always see that the trunk is erect whenever you are seeing this active range of motion when it comes to forward flexion and extension. This is abduction and adduction. In abduction, when you see, the palms are facing in front and the patient moves both the hands together in a synchronous way to reach the ear lobules. The normal range of abduction is 170 to 180 degrees. This is how one tests adduction. The patient is stable and the patient is asked to move his hand across his body to test for the adduction. External and internal rotation, where you see that the external rotation is about 80 to 90 degrees. Here the patient stands with the elbows hitched into the sides, and so that the elbows, they do not move, and gently the patient has to move the elevation. The normal external rotation is about 80 to 90 degrees. The external and internal rotation can also be tested in supine position, and we will come to that in next part of the presentation. When you come to the internal rotation in standing position, it is done by thumb hitching method, and you can see the scapular spine there correlates with the D7 vertebra, and the thumbs are reaching well above D7, which indicates that the patient has got a normal internal rotation, and it is identical on both the sides. Now we come to what is called as passive range of motion. What we have to see is when you see patient perform active range of motion, you have to do passive range of motion yourself. And in this situation, we have to see that the joint is moving through the glenohumeral joint, because in all the movements of the shoulder joint, it is not only the glenohumeral joint, but it is also the scapulothoracic movement, and which is also aided by movements of the acromoclavicular and sternoclavicular joint. So we have to isolate the glenohumeral joint in order to know what is the exact range of glenohumeral flexion, extension, abduction, adduction, horizontal adduction, horizontal abduction, external rotation, and internal rotation. So whenever you are doing a passive ROM, most of these tests are performed in sitting position except for rotation. Flexion, when it comes to flexion, you can see that one hand of the examiner is placed on the clavicle anteriorly and onto the scapula posteriorly. When you do that, what you're trying to do is trying to avoid the scapulothoracic movement. And in this situation, if you release this hand, the hand can further be elevated to the full range, that is 180 degrees. So the flexion and glenohumeral joint is 90 degrees and combined flexion is about 180 degrees. When it comes to extension, in a similar way, the clavicle and the scapula is stabilized and the hand is moved behind to see for active extension, which in normal patient should be about 60 degrees. In abduction, the glenohumeral movement is 90 degrees and the combined abduction is 180 degrees. Please pardon me for the mistake. I have written 18 degrees there, whereas adduction is glenohumeral 20 degrees and combined 40 degrees. So when you're doing the abduction, here again the hand stabilizes the scapula and the clavicle. And here, once you release the hand, there occurs the external rotation along with the abduction, to range of abduction, which is 180 degrees. So the combined movement is 180 degrees. Similar to abduction, in adduction, one has to stabilize the inferior angle of the scapula. As you saw here, this inferior angle of the scapula stabilized, the adduction is just sooner you leave the hand, you can further adduct it to another 20 degrees, giving rise to a 40 degrees of combined adduction. Recent gadgets have given us a little more of insight, and we can use smartphones to measure the shoulder joint movement. And with smartphone movements, there has been high inter-rater reliability of about 0.89%. By using smartphone, one can have a calculated external rotation and internal rotation. So if we go into the measures and go into the measures app, you will find that you will have a level there, and you can know the internal rotation and external rotation at the shoulder joint. Whenever you are testing this, again, you are going to stabilize the coracoid process, the video of which will come in the next slide. So here, when you see that the internal rotation is 83 degrees and external rotation is also 83 degrees, this means that the patient has got a TROM, which is a total ROM, which is sum of external rotation and internal rotation. Normally, it should be 135 to 180 degrees. In this patient, it comes to about 160 degrees odd, which suggests that the patient has got a normal range of TROM, that is total range of motion. The importance of this here is this TROM, if there is a side-to-side difference of more than 10 degrees, then it is said that it is of significance, clinical significance, or it is abnormal. Only internal rotation deficit of 10 degrees as compared to the opposite side does not really clinically signify abnormal shoulder pathology. So that is the way how it is done in supine position. You stabilize the coracoid process and then perform external rotation to achieve the true external rotation occurring at the glenohumeral joint. This is another test which will probably tell you about the functional status of the shoulder, which talks about almost all the movements occurring at the shoulder joint along with the scapulothoracic and the AC and SC joints. And Aplay's scratch test would give you a functional assessment of the shoulder. Here the patient moves hands in this fashion to touch both the fingers to each other. And in this situation, it is often seen that on the dominant side, the range of motion is less as compared to the non-dominant side, although that does not signify any disease, but a smoothness of this movement which is done by the patient would probably suggest a good shoulder dynamics and a good shoulder functional control. The scapulothoracic rhythm is the next which one needs to see for, and it is by far one of the most important things to see. As we have been talking, when you see in abduction, what happens here is it's not only glenohumeral movement, it is the scapula moving, it is the AC moving, it is the SC moving, and when you see that when it crosses beyond 90 degrees, where you see that the shoulder moves into external rotation. So scapulothoracic movement, one can see again, this is very, very important to see that whenever the shoulder is moving in full abduction, the glenohumeral joint always rotates, and there is an external rotation of 45 degrees which takes place to achieve full abduction. When you see it on the live patient, you will be able to see that this abduction occurs through the glenohumeral joint as well as the scapulothoracic joint, and you can see both the scapulae moving identically on both the sides. When this is happening, you can say that your shoulder kinematics are in perfect shape. If one scapula is not moving to the extent it should, that indicates that there is an altered scapulothoracic rhythm, and this is the first thing which one would like to get back whenever you are doing a shoulder rehab. When it comes to individual muscle testing, we call them as special tests. So we test for individual muscles to see for any shoulder pathology. And here we see that there is an evidence for each and every test which talks about the efficacy or the sensitivity and specificity of this test. So the first test is what is called as MTCAN or Job test, which is done for supraspinatus, and it is about 88% sensitive and 62% specific for supraspinatus. This test is done in standing position where the shoulder is elevated and then the patient is asked to internally rotate with the thumbs down and is asked to actively abduct against the resistance. If the muscle is weak or if it is weaker as compared to the opposite side or the patient complains of pain, we say that MTCAN test is positive. The second test is full CAN test. The full CAN test is again done for supraspinatus. The sensitivity is 70% and specificity is 81%. The test is performed in the same fashion except for now the thumbs are facing up and the patient is asked to abduct against the resistance. Here also weakness as compared to the opposite side or pain will suggest that there is a supraspinatus pathology, which could be positive in supratendinosis, it could be positive in supra tear. External rotation test or external rotation lag test is of questionable clinical importance, and it is done for both supra as well as infra. When in sitting position, stabilizing the scapula, the hand is held into external rotation position and the patient is asked to hold that position for a while. If the patient hand falls forward and is not able to hold this position, this suggests supra as well as infra insufficiency or rotator cuff tear. Lift-off test is done for subscapularis and the sensitivity is of 22% with a 94% of specificity. In standing position, the patient's hand is put at the back and patient is asked to lift off the examiner's hand out of his own body. Weakness here or inability to do this or pain during this maneuver suggests that the test is positive and talks about the subscap tear. There are certain other tests which can be done for rotator cuff, which are external rotation lag sign, a bear hug test for subscapularis, belly press test again for subscapularis. This is especially true when the patient cannot do abduction and external rotation or internal rotation as in adhesive capsulitis. I think belly press test would be the test which one would do for subscap rather than doing a lift-off test. And there is a hornblower sign which is specifically positive for teres minor and infraspinatus. Then we come to some tests for impingement. So subacromial impingement is a common ailment which we see in elderly patients, and Hawkins-Kennedy test for subacromial impingement is 80% sensitive and 56% specific. While doing this test, the patient sits on a couch, the examiner's hand goes onto the shoulder, and then with the other hand, the examiner internally rotates the shoulder. This maneuver pushes a greater tuberosity below the acromion, and if the patient has got bony or soft tissue impingement, the patient will complain of pain. And it is called as positive Hawkins sign, which will talk of subacromial impingement. Some other tests for subacromial impingement are Yoakum's test, Neal's test, Job's test, and a painful arc. We have not included all the tests as examination of the shoulder joint in itself is not a very valid kind of examination as we have seen in sensitivity and specificity of different tests. When you come to instability of shoulder dislocations or recurrent dislocations, apprehension test is one of the most important tests and has got a strong clinical value with a specificity of 95.4%. This is done in a lying down position, and we will come to that later as we see a second test for shoulder instability called as relocation test has got a moderate clinical value and a specificity of about 90.2%. These two tests, we will see as how they are performed. The patient is lying in supine position. The scapula is stabilized with the pressure on the coracoid. And the moment you do this, the patient has got apprehension on the face. So you have to see for apprehension on the face, or patient sometimes might tell you that the doc, it's hurting me, so please stop there. Sometimes you can even feel a pop, and if you feel this pop and you support the anterior shoulder with a thumb or a palm, you get a feel of relocation of a dislocated humeral head by doing this maneuver, and it's called as relocation test. Both these tests are done in supine position. Other tests for shoulder instability are release of surprise test, load shift test, Kim's test for posterior instability, and jerk test again for posterior instability. There is another common lesion which we come across in athletes, and that is a flap lesion. O'Brien's test is of weak clinical value with a specificity of just 36%. Although the O'Brien test is done in a standing position where the hand is forward flexed to 90 degrees, is adducted 10 degrees and internally rotated, and the patient is asked to push against the resistance. Here the pain or the click felt in the shoulder suggests that it's a positive clinical sign, and that would probably suggest that the patient has got a flap tear. Other tests for labral tears are Yergason test, Speech test, passive distraction test, and a crank test. AC joint pathologies are again common as the patient passes the middle age. And in this, the cross-body adduction test gives us a weak clinical value with 26% of specificity and 64% of sensitivity. It's done in standing position where the hand is elevated to 90 degrees of flexion, elbow is completely extended, and a cross-body adduction is performed. If the patient complains of pain at the site of acromion, we probably say that the patient has got an AC joint pathology. A second test is called a scarf test, wherein the patient puts his hand onto the opposite shoulder. It is elevated to 90 degrees and is pushed across the body. If the patient talks of pain at the acromioclavicular side region, it talks about AC joint pathology. So we have seen almost all common elements which a clinician can face or a general orthopedic surgeon can face in his clinic. And depending upon the history, presentation of pain, the time of pain, the restriction of the pattern or the movement of the shoulder joint, and by doing certain specific maneuvers, one can reasonably reach to a workable diagnosis. So to conclude, I would always like to say that before you start with your shoulder examination, never underestimate cervical spine. Always do clear the cervical spine before you see the shoulder. Examine the patient in all three positions, that is standing, sitting, and lying down. Make arrangements of sufficient privacy to examine the patient with the clothes off. Never see them with the clothes on. You will miss on very, very important information. Move, feel, and special test in a structured way is the way to go ahead. Never forget to see a scapulothoracic rhythm. And a good clinical examination, I must say, should not take you more than 7 minutes if you really follow a structured pattern of shoulder examination. Thank you for your attention.